We are the Center for Advancing Health Outcomes. Research that transforms care, policy, practice, lives. Visit us at advancinghealth.ca.
Thank you so much and welcome everyone for joining for today's Work in Progress seminar session. My name is John Erich. I work for the Center for Advancing Health Outcomes as the primary event coordinator. And it is my pleasure today to introduce you to our speaker, Dr. Tara Sedlak. Dr. Sedlak received her Doctor of Medicine, Internal Medicine residency and Cardiology residency from the University of British Columbia. She also completed a fellowship at Cedars-Sinai Medical Center in Los Angeles, California, on women's heart health, particularly focusing on chest pain syndromes in women with no significant coronary artery disease. Dr. Tara Sedlak practices general cardiology at Vancouver General Hospital and BC Women's Hospital and is the director of the Leslie Diamond Women's Heart Health Clinic. Her research interests include etiologies of myocardial infarction and chest pain in women with non-obstructive coronary artery disease and therapeutic strategies in microvascular coronary dysfunction and coronary vasospasm. We're very excited to have her here today, and with that, nothing else for me to do other than hand it over to Tara to get us started.
Okay, great. Can you hear me okay?
Yes.
Okay, excellent. Great. Well, thank you for the introduction and thanks for inviting me. Yeah, I wanted to take you through a tour of our women's heart health clinic and some of the data that we've produced from that, and some of the specific syndromes that we've looked at, which in the past have been sort of underdiagnosed and misdiagnosed in cardiology. Okay, there we go. I have a few disclosures, mainly Speakers Bureau and advisory boards. So first of all, I just wanted to touch on some sex and gender differences between men and women with respect to heart health. I wanted to review these entities, which I think a lot of people are not that familiar with, and the definitions of MINOCA and INOCA, and then causes, diagnosis, management. And then I wanted to spend the latter half of the talk really looking at our own Vancouver Women's Heart Center outcomes and our research and our data. So I have a couple of patients I wanted to go through just to sort of set the tone for the type of patients that we see in the Women's Heart Clinic. So this is one of our patients. She's a 62-year-old female, BMI of 31. She was previously asymptomatic, a little bit limited by knee and hip pain, but otherwise wasn't describing any angina or chest pain on a regular basis. She does have dyslipidemia. Her LDL is 4.4, triglycerides 2.2. She has impaired fasting glucose. A1C is 6.2. And she had an LP(a) done, and this was a few years ago in the older values, but nonetheless, it was quite high at 1700. Borderline blood pressure is 138/80 with preeclampsia and 2 prior pregnancies. And she has migraines and a family history of heart disease in her mother with an MI at the age of, or a heart attack at the age of 58. So she presented to us in the emergency room when she had a significant episode of chest pain, fairly crushing chest pain. And she herself was worried that she was having a heart attack at home. She called the EMS, they brought her in. She had a significant elevation in troponin levels, indicating a lot of heart muscle damage, up to 11,000. And she actually had some transient ECG changes that were quite worrisome that she was having an impending heart attack on the ECG. And so she was actually rushed in for an urgent angiogram, which is felt to be our gold standard test, where we literally go in through the groin or the wrist, up to the heart, put dye into the artery surrounding the heart, and we look for a blockage. And lo and behold, you can see her diagram there. Those are her arteries, and they're completely clear. So no major blockage. And when in fact, we were expecting to see 100% blockage given the changes on her ECG and her troponin level. And so no indication for bypass surgery, no indication for a procedure called stenting or angioplasty, where we put a balloon in with a stent loaded on top of it and open up a blockage. It was read as being a normal angiogram. And so then she was brought back to the CCU cardiac care unit where an MRI was performed. And the MRI, you can see in the bottom here, demonstrated within different segments of the heart, but predominantly anterolateral, which is the front part of the heart, that there were some changes and some delayed enhancement in keeping with an acute myocardial infarct, which is literally a heart attack. So here we are. She's had a heart attack for all intents and purposes on blood work, by symptoms, by ECG, and by an MRI, and yet her angiogram is normal. So where are we left with this? So in her, you could tell that there was a bunch of what we call sex-specific risk factors. And I highlight this because some of our research will come to this at the end. And what we know now in the last 10 to 15 years, and what we sort of didn't know in the past because we weren't studying women as much as we have been more recently, is that certain sex-specific risk factors can increase a woman's risk for heart disease down the road. Those include hormonal aspects. So polycystic ovarian syndrome can increase the risk of heart disease. Also, early menopause, so premature menopause before the age of 40 can actually greatly increase the risk of a future heart attack. And then finally, pregnancy-related risk factors, so gestational diabetes, placental abruption, premature delivery, stillbirth, preeclampsia, high blood pressure during pregnancy. All of those can almost double the risk of cardiovascular disease down the road. And in fact, she had numerous of these in her history. We know that inflammatory risk factors now are very important. So you can see here, this is rheumatoid arthritis with the woman's hands, and then this is lupus with the rash on the face. And in women who have these types of entities, it can double the cardiovascular risk. And finally, we know that breast cancer, we've done a great job at treating breast cancer. And in fact, more than ever, we have significant advances in breast cancer and chemotherapy, radiation therapy, and even surgeries. But what we know now is that women aren't necessarily dying of their breast cancer. They're actually having cardiovascular disease down the road. And some of that is from the chemotherapies with regard to actually causing damage done to the heart and heart failure. Anthracycline-based therapies are classic for that, or a newer one called trastuzumab. And then also radiation therapy is very important, especially left-sided radiation therapy, where you can see there in the red where radiation therapy can overlie parts of the heart. And when it overlies parts of the heart, you can actually develop narrowing or fibrosis and scarring in the arteries surrounding the heart. In particular, the artery coming down the front of the heart can become narrowed over time and can lead to heart attacks and chest pain, etc. So we recently published in the Canadian Journal of Cardiology, which is one of the major cardiology journals in North America, on this entity called MINOCA. And essentially what it is it's a myocardial infarct, so a heart attack with no obstructive coronary artery disease. And what I mean by that is where you go in, you do the gold standard test, that angiogram, and you don't find an obstruction or a blockage in the arteries. And so really this falls under sort of acute coronary syndromes. And I'm going to talk a little bit about stable coronary syndromes as well before I get to our research. But essentially in red here, acute coronary syndrome is an acute incident, chest pain, often in the emergency department, diagnosed as a heart attack, or what we call STEMI versus non-STEMI, which is essentially a heart attack caused by a blockage, opened up by a balloon and a stent. But there certainly is a proportion of these patients where you go ahead and you do the angiogram and it's normal, and we call that MINOCA. And about 6% of all acute coronary syndrome is MINOCA, and it's 10% in women. So there is a sex difference here, and 3% in men. So at the end of the day, what we've sort of said in our guidelines or in our consensus document is that they have to really present as if it's a heart attack. So similar to our woman where she had crushing chest pain, she had that nice rise in troponin level indicating heart muscle damage, plus or minus ECG changes. So really, at the end of the day, you think the patient is having a heart attack. And in fact, you're going to do an angiogram, the gold standard test, thinking that there's a blockage there. But then number two is you go ahead and you do the angiogram, and lo and behold, you do not find a major blockage. And in fact, you find no major blockage, nothing over 50% in any of the large blood vessels surrounding the heart. And then finally, there can't really be another cause for the presentation. So for example, if somebody's found to have a pulmonary embolism, which is a clot in the lungs, that can cause a lot of the similar symptoms and a lot of the similar characteristics. And of course, they would have normal arteries, but they would have clot in their lungs. Well, you wouldn't necessarily call that MINOCA because you found another cause for their presentation. So what we've determined is that there are various causes of MINOCA that I must say over 10 to 15 years ago were really unrecognized. And still, at the end of the day, here in red, you can still have atherosclerosis, which is plaque in the arteries and clot, causing a heart attack. And yet by the time you get to the angiogram, sometimes it's done immediately, but sometimes it can be done hours or days afterwards, and they're already treated with blood thinners and other medications. By the time you get to the angiogram, it doesn't show that blockage that you initially would have found had you gone in immediately with the angiogram. So still atherosclerotic causes are an important cause. We also know that there are non-plaque related causes. In fact, often in young women, we'll find something called SCAD, which is a dissection or a tear in the artery, where the artery can actually tear or dissect. There's no plaque inside the artery. There's no clot per se. There's actually a tear in the artery, and that damages the artery and causes the heart attack. Embolism, which is a clot, just like you can get a clot in the lungs, you can get a clot going down the arteries of the heart. It's rare, but nonetheless, it occurs. And then spasm of the artery, where the artery can start off normal and can spasm down and then let back up again, can cause both chest pain and a heart attack if severe enough. There's also small blood vessel dysfunction. I'm going to talk about that more in the latter part of the talk, but essentially where the tiny blood vessels surrounding the heart are abnormal, and we don't necessarily see all of those on a straightforward angiogram. And then finally, there can be mimickers, which are very important, and these are actually more common in women, in particular, an entity called Takotsubo cardiomyopathy, which is a stress-induced cardiomyopathy, where there's a lot of stress on the heart, overwhelming stress, often an emotional stressor or physical stressor in a woman's life. And then she has what's called a broken heart syndrome, where it really overwhelms the heart. The heart doesn't function well, it doesn't pump well, and it mimics a heart attack. But there's actually no blockages in the arteries and nothing wrong with the heart itself. Myocarditis, which is a virus of the heart, certainly we've seen that both in men and women, and it can very much mimic a heart attack as well. So why does it matter at the end of the day trying to figure out which of these entities a patient has? Why can't we just call it MINOCA? Well, because they're all treated differently. So if you find that, in fact, there was missed plaque inside the arteries that wasn't picked up on the angiogram, but maybe is picked up on a different tool that we'll talk about in a bit, such as a specialized angiogram where you put a camera down the artery, then you would treat them as if it was plaque in the arteries with blood thinners and cholesterol-lowering agents, blood pressure-lowering agents, etc. If you find that they have this dissection or SCAD, that's treated with a beta blocker to try and lower heart rate and blood pressure so that you don't sort of have extension of that dissection. If you have an embolism or a clot, that's treated with a blood thinner. If you have spasm of the arteries, treated with a vasodilator. So you can see here that depending upon what the cause is of the heart attack, all the different treatments may be different. And for everybody, of course, we try to refer them to cardiac rehabilitation, risk factor management, psychosocial support. And then if an answer can't be found at the end of the day, maybe referral to a center of excellence. This also matters because of prognosis. Certainly when you have blockages in the arteries, so that's obstructive coronary disease here in the dotted line, you have a higher risk of recurrent events, mortality, recurrent heart attacks. If you have completely normal arteries and no prior history of a heart attack or no prior history of any cardiovascular disease, of course, you do very well. And it turns out that this MINOCA has an intermediate prognosis that certainly is not as high as having obstructive coronary disease, but certainly not normal. So another patient that we've seen in our Women's Heart Center is that of a 65-year-old female. She has diabetes and high blood pressure. She's on ramipril, a statin medication for cholesterol, and metformin for diabetes. These are all pretty typical medications used for management of her risk factors. And she actually presented not with a heart attack, but she presented with chest pain. And it was going on for months. And sometimes it would occur on exertion, sometimes at rest, sometimes it would last for up to 20 minutes. And, you know, she was worried enough that she saw her family doctor. Her family doctor ordered a stress test, which is often an initial test that we do in cardiology, especially as an outpatient. And that was positive for ischemia. And what that means is that it's abnormal enough to look like there's a lack of blood supply to the heart. And in fact, it was worrisome enough to the person reading the test, who was a cardiologist, that they actually saw her that day while she was having the stress test in consult, thinking that she had an impending blockage in her arteries, and started her on aspirin, a nitroglycerin spray, a cholesterol-lowering agent, and a beta blocker to try and sort of help with her chest pain, and arranged for a semi-urgent outpatient angiogram, which is, again, that gold standard test looking at the arteries, and it was completely normal. So at that point, she was kind of reassured and told, well, geez, everything looks pretty good. This must not be your heart. The stress test must have been a false positive. Stop all your medication. And in the interim, you know, she wasn't that clear whether the beta blocker had helped anyways, but she actually did try the nitroglycerin spray and did feel that it helped. She went for a workup for her esophagus. She actually had a scope down looking for other causes. For her chest pain, all that was normal. She tried an antacid for months, didn't make any difference. And she actually continued to have ongoing chest pain, often when she would exercise, but sometimes at rest, relieved with a nitro spray. And so based upon this, she was referred to our heart clinic for further workup. So this we call INOCA. And INOCA is the stable counterpart to MINOCA, which is basically ischemia, or a lack of blood supply to the heart, but no obstructive coronary disease, so no blockages in the arteries on a standard angiogram. And similar causes, so you can certainly have spasm of the arteries surrounding the heart that can cause this. You can have small blood vessel disease that causes this. You can even have something called a bridge, which is a congenital abnormality where the arteries start off on the outside of the heart, dive down into the muscle of the heart and come out on the other side. And when that bridge is going through the muscle, if you have a lot of compression on that, that can cause chest pain. But of course, we're trying to sort out in these patients, you know, whether it could actually be non-cardiac. We know that stress tests are not that reliable in women. You can have false positives. Chest pain can be caused by all sorts of things, such as musculoskeletal, esophageal spasm, even mental health can cause chest pain sometimes. And so there's always a differential behind this. So one of the major diagnoses, excuse me, that we come across is microvascular dysfunction. And that's really disordered functioning of these smaller coronary resistance vessels, where the small blood vessels surrounding the heart can become dysfunctional. The blood flow in those smaller blood vessels is not normal. And then essentially you can get chest pain from that, or occasionally you can get a heart attack from that. And so now, thankfully, there's actually a universal definition of microvascular angina. If we go back many years, in fact, when I was training over 15 years ago, and we look at the textbooks, they used to call this syndrome X. And they would call it syndrome X because they really didn't know what it was. And they knew it was more common in women. So hence the X. They didn't know what it was, so they called it just syndrome X. And basically, it was women who had chest pain, and yet you'd go and do an angiogram and everything would be normal. But now we know, of course, that it's due to the small blood vessels for the most part. And so, you know, if you have the top three there, 1, 2, and 3, which is symptoms of angina, no blockages in the arteries, but you have some ischemia or lack of blood supply, like our woman did on stress testing or other testing, then you have probable microvascular dysfunction. And then we actually, and others have developed a technique going down into the small blood vessels of the heart. And we do this here at VGH at least several times a month, where not only do we look at the large blood vessels during an angiogram, but we actually put a wire down into the small blood vessels and test their function and measure the coronary flow and measure the resistance inside the small blood vessels. And if you have abnormalities in that, then that is definite coronary microvascular dysfunction. And there are various causes of microvascular dysfunction or coronary microvascular dysfunction, CMD. And a lot of those come back to some of those sex-specific precursors we talked about, early menopause, PCOS, pregnancy-related risk factors, autoimmune conditions that we talked about. vasculopathies, and then of course standard risk factors, cholesterol, high blood pressure, smoking, diabetes, etc. We've tried to look at various ways to diagnose microvascular dysfunction. One of the upcoming sort of techniques is that of perfusion MRI. Because what would be nice is instead of always having to do an invasive test, which carries some risk, i.e. the angiogram and going down to the small blood vessels and testing their function, we would like to be able to do a non-invasive test to try and diagnose this condition. Admittedly, it's still a work in progress. I mean, MRI from a practical approach is nice in that there's not a lot of radiation with it. And it shows things like subendocardial perfusion, which is really the area that we're trying to look for in terms of the small blood vessels. It can show you if there's scar inside the heart, if you've had a prior heart attack. It can look for thickening of the heart muscle or other things that could cause chest pain. And then more recently, we've been looking at this entity called MPRI, which is really the notion that you can measure coronary or myocardial blood flow during an MRI. You give adenosine, which is a stressor agent, and you measure blood flow again, and then you look at the ratio. And ideally, with adenosine, which is a hyperemic stimulus and should increase blood flow to the heart muscle, in patients in whom they have microvascular dysfunction, they have a blunted response. Still, in our research and other research from the States, I would say that the sensitivity and specificity of perfusion MRI, even with the calculation, is somewhere in the 75% range. So it's still not ideal. We've done some work on cardiac PET, although again, more research needs to be done on this. Unfortunately, in the province of British Columbia, we don't really have access much to cardiac PET, but certainly I was just at a conference in Ontario and they use cardiac PET a lot. There's good prognostic data showing that, again, you can give a stressor during the PET scan. So you look at the blood flow at rest, you look at the blood flow with a stressor agent, and if you have an abnormal stress or a stress response, meaning that your blood flow does not increase by at least twofold, so it's less than 2, even if you've had a heart attack or if you're in the group that has not had a heart attack, your prognosis is worse than any other group that we look at. So certainly we know that if we can pick up on abnormal coronary blood flow, those patients do worse. And this is our coronary reactivity testing that we do in the angiogram lab several times a month on patients, mainly in patients in whom we can't get a diagnosis any other way. And we really need the diagnosis and decide to go the invasive route. And this is really where we're going into the arteries, again, making sure that large blood vessels are normal, and then going down into the small blood vessels of the heart to test their function. And we test it with adenosine, similar to what you would give during an MRI or during a PET scan. And then we also give an agent called acetylcholine, and that can look for spasm of the arteries, both spasm of the large blood vessels surrounding the heart and spasm of the small blood vessels of the heart. Excuse me. So this is the treatment of microvascular dysfunction. And as you can see here, there's not a one size fits all. There's actually a lot of different things that we can do for these patients, but it's been relatively understudied. And larger trials are now finally ongoing to look for targeted therapies for small vessel dysfunction. But suffice it to say, currently, we certainly try to get their angina or their chest pain under good control. So we'll give them agents such as beta blockers, calcium channel blockers, nitroglycerin, a newer agent in Canada called ranolazine that works quite well in these patients. We'll work on the risk factors, lowering blood pressure, lowering cholesterol to try and reduce their risk of a bad outcome. There's some novel therapies where some newer trials are looking at some of the diabetes medications, endothelial antagonists, even gene-based therapies. All of those are ongoing right now, so we don't have an answer as to whether any of those will be helpful. And then some patients, have such severe pain that we actually do a real holistic approach. We have a psychiatrist as part of our Women's Heart Center, and we offer cognitive behavioral therapy and other therapies related to that. We have referrals to the St. Paul's Pain Clinic, sometimes for a spinal cord stimulator in those patients who have really severe pain and their pain needs to be really managed better. So it sort of is a really holistic approach to these patients. So that sort of background brings me to a lot of the research that we've been doing, which is really trying to answer the question of whether a women's heart center improves outcomes in this specific set of patients with MINOCA, with the actual heart attack, or INOCA with more just the chest pain, particularly in women, because it's been understudied and underdiagnosed in women. So we wrote an article a few months ago published in Canadian Journal of Cardiology, and essentially what we looked at is what are some of the issues related to women's heart health, and how can a women's heart center sort of target those different issues? And I realize this is a bit of a busy slide, but essentially here in blue, we're kind of getting at the fact that sometimes symptoms are dismissed, sometimes they're misdiagnosed, sometimes they're even medically mismanaged, or we just don't know the diagnosis. And so a women's heart center, really sort of hones in on some of these important symptoms, and some of them can be different between men and women, knowing some of these unique causes of heart attack in women, not the standard sort of blockage in the arteries, having some of the appropriate testing, so access to MRI, access to that specialized reactivity testing where we go down into the small blood vessels and test their function. So all of that could potentially be helpful through a women's heart center. In purple is a lot of the mental health aspects that go along with women's heart health. And some of it is that these women have been misdiagnosed or underdiagnosed for years. They've often have chest pain daily for years, kind of told that it's in their head. And a lot of them have developed some overlying anxiety and depression. And so we offer a peer support program led by one of our women with lived experience. We offer cognitive behavioral therapy and psychiatry and psychology support. And then finally in the pink here is really that women's heart research has traditionally been under researched and sort of underfunded. And now, thankfully, in the last 10 years, with a lot of the work done by Heart and Stroke, CIHR, and others, have really brought it to the forefront, where they've really said, inclusion of women in sex-specific criteria in clinical trials, really bringing forward sort of sex and gender aware curriculum in medical school and high schools, et cetera. Increased funding opportunities for women's heart health through both CIHR and Heart and Stroke. And then we've developed a National Advocacy Day, which is on February 13th, Wear Red Canada Day, where we get out and we do a lot of advocacy campaigns and get out in the public and really raise awareness about women and heart disease. So recently, we did an abstract. Jocelyn Chai, who's one of our fellows, and Emily Thegberg, who is our excellent research coordinator, did an abstract just looking at if a woman presents to hospital with a heart attack, is found to have this umbrella term of MINOCA, where she doesn't have a blockage in the arteries, what is she sort of discharged home on in terms of medications? And it's a real mishmash, because again, if you don't have a specific cause for why the heart attack occurred, you really don't know what to prescribe. And that's what we found in our research, is that really it was across the board. Some people were being discharged home on nothing, some people a daily aspirin, some people a nitroglycerin spray, some people were discharged home on 5 medications, didn't even know why they were taking them. So it was a real, really driven by lack of diagnostic clarity. And in this study and our upcoming study, which I'll show you in a minute, you can see on discharge, a lot of patients really were in this sort of MINOCA umbrella, where they were told that, yeah, they probably had a heart attack, but we don't know why. A few actually did have a diagnosis when they left hospital. But then by the time they got to Women's Heart Clinic, and we were able to provide them with a lot of those services that I showed you in that original diagram, then we were able to get them an answer. And in fact, most of the time we could get them an answer as to what actually caused their heart attack. And through that, then we were able to hone in on the medications better, where we would start off sort of with this MINOCA kind of NYD, where they'd be on all sorts of different medications, not really sure why they were taking them. And then we would find that, maybe they had a very specific diagnosis, vasospasm, or this dissection in the artery, or microvascular dysfunction, or missed plaque rupture. And then we would really hone in on getting them, on the right medication. So for example, for missed plaque rupture, you really want to have them on all the agents that you would normally have them on for plaque in the arteries. And we found that once we had the diagnosis correct with the proper tools, then they got on the right medication. So we've now been able to publish on both our 1-year follow-up of INOCA and MINOCA patients in our Women's Heart Center. And now just recently in the last few months, we published on our 3-year follow-up of those same patients. And we're hoping to do 5-year follow-up in everyone with about 500 women. Currently, we have just over 400 in our data set. But in these studies, because of course we were looking at 3-year follow-up, we were looking at smaller numbers. So essentially we had 182 women. Some of them actually ended up having exclusions. And so we basically looked at non-obstructive coronary disease, so MINOCA and INOCA cohorts. Again, this is the 3-year follow-up. So remembering that, we have over 400 women now with MINOCA and INOCA, and the hope is that if we follow them for long enough, we'll have much larger data sets long-term. But suffice it to say, this is a similar diagram as I just showed you with our abstract, but just showing that prior to coming into a women's heart center, about 80% of women had no diagnosis. They knew that something was wrong. They were told there was something wrong, but they were told all their testing was normal, and it likely either was not their heart or it was unknown. And really by the end of it, excuse me, we were able to improve the diagnostic yield from 80% having no diagnosis down to 4% having no diagnosis. And a lot of that is just all of those tools that we talked about that were available in a women's heart center that wouldn't be available elsewhere. Majority of them were that microvascular dysfunction that I talked about, so small blood vessel disease and spasm of the arteries, but certainly we had other entities as well. With regard to angina, so we did SAQ scores. So this is Seattle Angina Questionnaires at baseline, 1-year, 3-year, and 5-year. And really just looking to see whether people improved with some of our treatments. And you can see in purple is improvement, and most people did improve. In gray, no change. So certainly some people had no change. And then a few people in blue did worsen over time. And unfortunately, the natural history of the disorder is that often women do worsen over time, but thankfully we were able to improve a large proportion of patients with regard to their angina and quality of life. Diagnostic clarity really informed medical management changes, and I kind of showed this in our abstract, but this is in our paper, just showing that in orange is sort of baseline, and in blue is our 3-year data, just looking at our medications, and you can see here that there's a significant increase in medication prescribing once a diagnosis was made, and actually some of these have very specialized sort of agents called ranolazine, and as I mentioned, spinal cord stimulators, and a lot of those were used in patients once we kind of had a diagnosis and said, yes, this is cardiac, yes, we know what you should be on, or yes, we think you need this procedure, and then going for that. So again, coming back to the thought that, getting the diagnosis and then following through on the treatment plan. Thankfully, we were able to show a reduction in emergency room visits and hospitalizations comparing pre and post. So we would look at the years before the diagnosis and then the years after the diagnosis, remembering most of these patients have had chest pain for decades, sometimes at least 10 years often. And so just being able to show that we were able to reduce emergency room visits significantly, down from 63% to 39% of patients presenting to the emerge on a yearly basis, and then reducing cardiac hospitalizations as well, which cost the system money. We were down to about 6% of patients were still needing to be hospitalized compared to 15% before. Finally, we actually improved mental health, which was a great outcome. And this was in large part due to our psychiatry support and our peer support. So we were able to significantly improve mental health on several different scales. We actually studied cardiovascular risk factors as one of our outcomes in these studies. And the main reason we studied cardiovascular risk factors was because we had the thought that some of the risk factors for these entities of MINOCA and INOCA were probably not classically traditional risk factors. And I sort of mentioned that at the beginning, that there were these sex-specific risk factors that we were just seeing a lot in our patients, and noticing that there was sort of a trend towards, geez, maybe these were significant risk factors. And so what we did was we compared our data set, which was largely women who had open arteries, so no blockage in the arteries, and then various causes for their MINOCA or INOCA. And we compared that to the SAVE BC registry, which is a great registry by Dr. Pimstone and Dr. Brunham. And they looked at patients who are younger patients who've had early heart attacks or early angina and blockages in the arteries. And so what we did was we compared those two. So in orange is the patients who have blockages in the arteries and are under 55 years of age and female. And in green here is the patients who are female under 55 years of age and have open coronary arteries. And we wanted to look at the risk factors. And basically what we were able to show was that in patients who have obstructive coronary disease, so that's blockages in the arteries, typical risk factors that we would normally ask about, like diabetes and cholesterol and family history and obesity and smoking, were very common. And in fact, what was significant was that in these MINOCA and INOCA patients, while they did have a few risk factors, very few of them would have a lot of those risk factors. And so I think if you just ask about traditional risk factors like cholesterol and diabetes and smoking, you may think that, geez, this patient is low risk for heart disease. But in fact, what we found was that a lot of these patients actually had other risk factors. They would have depression or anxiety, they would have autoimmune disease, they would have migraines, they would have preeclampsia or pregnancy-related risk factors that, to be honest, were not being asked about on a reliable basis by a lot of practitioners. And so we were asking reliably about these and actually found that they were much more common in patients with MINOCA and INOCA. And while they were still occurring in patients with obstructive CAD, less so, or they may just have, one of these risk factors, but not sort of more than one of these risk factors like INOCA and MINOCA. And so really the bottom line to this, and what I've been teaching a lot of the residents and fellows, is you can't just ask about traditional risk factors. You need to ask about sex-specific risk factors so that you get the real full picture of whether they might be at risk for one of these MINOCA or INOCA entities. So going back to our cases, because I want to leave some time for questions, you may remember our first case was that of a 63-year-old female with non-traditional risk factors. So she had a lot of sex-specific risk factors during pregnancy and et cetera. She had a heart attack. For all intents and purposes, she presented to hospital with chest pain that was dramatic. She had a rise in this troponin level, which only comes from heart muscle. She had ECG changes, and she had an MRI, which showed that she had a heart attack, and yet on her angiogram, she really had no significant disease. And so we used one of our specialized techniques where we put a camera down the artery and had a look. We could not find any blockage, no missed plaque rupture, no missed blockage. But in fact, what happened during her angiogram is she actually had one of her episodes of chest pain, and she had her changes in her ECG, and actually we noticed spasm of the artery. And so we were able to make a definitive diagnosis through that. And we got her on the appropriate therapy, which is a vasodilator. She was on aspirin and statin for prevention, and actually saw her recently after 5 years, and she's actually been chest pain free, which is pretty amazing because she had a lot of chest pain prior to her diagnosis. The second case was not that of a heart attack. That was of a woman who was having ongoing chest pain, presented to the emergency room a lot of different times with what we would call an INOCA, where she had chest pain and changes on her stress test that looked like a lack of blood supply to the heart, but every time she had an angiogram done, no blockages in the arteries. And we did invasive testing on her where we went down to the small blood vessels, tested their function, and found that she had abnormal microvascular response during the test. And so she was diagnosed with definitive coronary microvascular dysfunction. She was already on some secondary prevention medications because she was diabetic, high blood pressure, dyslipidemia. We started her on a beta blocker just to see if that would help. She really only had a partial response to that in terms of her angina, but then we were able to start her on ranolazine, which is a very specialized sort of newer anti-anginal therapy in the last 5 years, now available in Canada. And that greatly improved her chest pain, and she's done very well from that approach. So just in the last minute or so, I just wanted to talk about, why is funding needed for women's heart health? Certainly, I think I've made a case that, women in the past have been underrepresented in research, and that, most research in women in the past was actually extrapolated from men. And it was not really until the last 10 to 15 years when we started studying women and some of these sex-specific risk factors and some of these sex-specific entities like small blood vessel disease that we realized, geez, there's all these entities that can be different and can be unique in women, and really bringing that to the forefront to help make the diagnosis. And sometimes specialized testing is really needed to help make the diagnosis in some of these really difficult cases, and not sort of relying on what we would call the gold standard, which is an angiogram, and actually going further and trying to really figure out what's causing their chest pain, or what was the cause for their heart attack. And of course, women are different. There's pregnancy, there's hormones, there's menopause. And so, all of the research on that has really come to the forefront in the last couple of years. So with that, I'd just like to summarize and say that, sex and gender differences in heart health do exist, certainly at all different levels in terms of risk factors, causes of heart disease, even sometimes presentation and symptoms can be different. These entities that we've really honed in on in our Women's Heart Center called MINOCA and INOCA, where you have normal large arteries surrounding the heart, but you've had a cardiac event, or you've got chest pain. There's still care gaps in these entities, but I think we've done a reasonable job at trying to identify causes and diagnosis and management in these patients. And then I think our research, our 1-year data and our 3-year data, and hopefully our 5-year data, which we'll publish in a few years' time, will show that referral to a Women's Heart Center seems to improve some of these care gaps in these patients. And with that, I'd like to thank WHRI, Catalyst Grant, who really helped us with the funding for this. BGH Research Group have really helped us recruit patients and follow patients. Leslie Diamond herself, so she funds our clinic, but she also funds our research. And for a while there, she was actually funding all of our microvascular testing until the government, because of our research, started paying for some of this testing. Emily Fayberg, who's our excellent research coordinator, and all the residents and fellows who've been part of our research and our studies. And with that, I wanted to end off and ask if anyone had any questions.